As we already studied action potential of heart in our previous video, let's brief it. The electrical event that normally take place in the heart initiate cardiac contraction. Disorders in electrical activity can induce serious and sometimes lethal disturbance in cardiac rhythm. Two main type of action potential take place in the heart. One type the fast response and another type is slow response. Fast response occur in normal atrial and ventricular myocytes and the specialized conducting fiber or Purkinje fibers. The other type of action potential, the slow response, occur in sinoatrial node and in the atrioventricular node. In fast response, the rapid upstroke of the action potential is designated as phase 0. The upstroke is followed immediately by a brief period of partial early repolarization, phase 1, and then by a plateau, phase 2, that persists for about 0.1 to 0.2 second. Then the membrane then repolarize in phase 3 until the resting state of polarization. Phase 3 is known as final repolarization. Phase 3 develop more slowly than does depolarization. That is, a resting state of polarization is phase 4. Now let's study phase 0 of fast response. Phase 0, which is genesis of upstroke, any stimulus that abruptly change in the resting membrane potential to a critical value is called threshold, results in the action potential. Rapid depolarization, phase 0 is related almost exclusively to the influx of sodium ion into the myocyte due to a sudden increase in conductance of sodium ion. The amplitude of the action potential, the potential change during phase 0 vary linearly with the logarithm of outside concentration of sodium ion. When outside concentration of sodium ion is reduced from its normal value of about 140 millimolar to about 20 millimolar, the cell is no longer excitable. The physical and chemical forces responsible for this transmembrane movement of sodium ion is showing here. When the resting membrane potential difference is suddenly changed to the threshold level of about minus 65 millivolt, the properties of the cell membrane change dramatically. Sodium ion enter the myocyte through a specific sodium fast channel that exists in the membrane. This channel can be blocked by pufferfish toxin tetrodotoxin. Also, many of drugs used to treat certain cardiac rhythmic disturbance, cardiac arrhythmias, act by blocking this fast sodium channel. The manner in which sodium ion move through this fast channel suggests that the flux is controlled by two types of gate in each channel. One of these M gate tend to open the channel as potential difference become less negative. This is therefore called activation gate. The other gate is H gate. Tend to close the channel as potential difference become less negative and hence is called inactivation gate. The M and H designation were originally implied by Hodgkin and Huxley in their mathematical model of impulse conduction in nerve fibers. As we have seen, potential difference of resting cell is about minus 90 millivolt. The M gate closed and H gate are wide open. Because the concentration of sodium ion outside of the cell is greater than the sodium ion concentration inside the cell, the interior of the cell is electrically negative with respect to exterior. Hence, both chemical and electrostatic forces are oriented to draw sodium ion into the cell. The electrostatic force is a potential difference of 90 millivolt and is represented by a white arrow. The chemical force based on the difference in sodium ion concentration between the outside and the inside of the cell is represented by black arrow. For a sodium ion concentration difference is about 130 millimolar. Because as we know, extracellular concentration ion for sodium is 145 millimolar and intracellular concentration of sodium ion is 10 millimolar. So the difference is 130 millimolar. A potential difference of 60 millivolt with the inside more positive than the outside is necessary to counterbalance the chemical or diffusional force according to Nernst equation for sodium ion. Therefore, the net chemical force that favor the inward movement of sodium ion is equivalent to the potential difference, that is 60 millivolt. In resting cell, the total electrochemical force that favor the inward movement of sodium ion is 150 millivolt. The M gate are closed. However, the conductance of the resting cell membrane to sodium ion is low. Therefore, in resting state, virtually no sodium moves into the cell. Any stimulus that make potential difference less negative tend to open the M gate and thereby tend to open the fast sodium ion channels. The precise potential required to open the M gate and thus activate the sodium ion channel varies somewhat from one channel to another in the cell membrane. As potential difference become progressively less negative, more and more M gates swing open and the influx of sodium ion accelerate. The entry of sodium ion into the interior of the cell neutralize some of the negative charge within the cell and thereby make potential difference still less negative. The consequent in potential difference then open more M gate and augment the inward sodium ion current. This process is called regenerative. As potential difference approaches about minus 65 millivolt, the remaining M gate rapidly swing open in fast sodium ion channel until virtually all the M gate are open. The rapid opening of M gate in the fast sodium ion channel is responsible for the large and abrupt increase in sodium ion conductance that occur in phase 0, the upstroke of the action potential. The rapid influx of sodium ion account for the steepness of the upstroke of action potential. The maximal rate of change of potential difference vary from 100 to 200 volt per second in myocardial cells and from 500 to 1000 volt per second in Purkinje fiber. Although sodium ion that enter the cell during one action potential alter potential difference by more than 100 millivolt. The actual quantity of sodium ion that enter in the cell is so small that the resultant change in intracellular sodium ion concentration cannot be measured. Hence, the chemical force remains virtually constant and only the electrostatic force changes throughout the action potential. In this figure, note that the length of black arrow remains constant, denoting a chemical force of 60 millivolt, while the white arrow change in magnitude and direction. As sodium ion rush into the cardiac cell during phase 0, the negative charge inside the cell are neutralized and potential difference become progressively less negative. When potential difference fall to 0, an electrostatic force no longer exists to pull sodium ion into the cell, as long as the fast sodium ion channel are open. However, sodium ion continue to enter the cell because of large concentration of gradient. This continuation of the inward sodium ion current causes the inside of the cell to become positively charged. This reversal of membrane polarity is so-called overshoot. Of the cardiac action potential. Such a reversal of electrostatic gradient would of course tend to repel the entry of additional sodium ion. However, as long as the inwardly directed chemical forces exceed the outwardly directed electrostatic forces, the net flux of sodium ion is directed inward, although the rate at which sodium ion enters the cell diminishes. The inward sodium ion current finally stops when the H inactivation gate closes. Like the activity of the M gate, the activity of H gate is governed by the value of potential difference. However, the M gate opens very rapidly in about 0.1 millisecond, whereas the closure of H gate requires a few milliseconds. Phase 0 is finally terminated when all of the H gate have closed, thereby inactivating the fast sodium ion channel. The closure of H gate so soon after the opening of M gate account for the quick return of the conductance of sodium ion from its maximum to its resting value. The H gate then remain closed until the cell has partially repolarized during phase 3. At about time D, from time C to D, the cell is in affective refractory period and will not respond to further excitation. This mechanism prevents a sustained tetanic contraction of cardiac muscle. Tetanic contraction of the ventricular myocyte would retard ventricular relaxation and therefore interfere with the normal intermittent pumping action of the heart. About midway of phase 3, time D, the M and H gate in some of the fast sodium ion channel have resumed state. Such channels are said to have recovered from inactivation. The cell can begin respond to further excitation. Throughout the remainder of phase 3, the cell complete its recovery from inactivation. By time E, the H gate has reopened and the M gate has reclosed in all the fast sodium ion channel. That is, they have resumed the status deposited. Let's go with the phase 1. Genesis of early repolarization of fast response. In many cardiac cells that have a prominent plateau, phase 1 constitute an early brief period of limited repolarization. This brief repolarization is represented by a notch between the end of the upstroke and the beginning of the plateau. Repolarization occurs briefly owing to activation of transient outward current carried mainly by potassium ion. Activation of potassium ion channel during phase 1 causes a brief efflux of potassium ion from the cell. Because the interior of the cell is positively charged and because the internal potassium ion concentration greatly exceeds the external potassium ion concentration. As a result of this transient efflux of positively charged ion, the cell is briefly and partially repolarized. The phase 1 notch is prominent in ventricular Purkinje fiber and in myocyte located in epicardial and mid-myocardial region of the ventricular wall. However, the notch is negligible in myocytes from the endocardial region. The cycle length of depolarization also appears to affect phase 1, when the basic cycle length at which the epicardial and myocardial fibers are depolarized is increased from 300 millisecond to 8000 millisecond. The phase 1 notch become more pronounced and the action potential duration is increased substantially. The same increase in basic cycle length in endocardial fiber has no effect on phase 1 and only a small effect on the action potential duration. In the presence of 4-amino pyridine, which block the potassium ion channel that carry to I2, the phase 1 notch become much less prominent in the action potential recorded from the epicardial and mid-myocardial region of the ventricles. Let's go with the phase 2 genesis of plateau in fast response. During the plateau of the action potential, calcium ion enter the myocardial cell through calcium ion channel, which activates and inactivates much more slowly than do the fast sodium ion channel. During the flat portion of phase 2, this influx of positive calcium ion is counterbalanced by the efflux of positive charge carried by potassium ion. Potassium ion exists through channels that conduct mainly to the I2, IK and IK1. The I2 current is responsible for phase 1, as described previously, but it is not completely inactivated until but it is not completely inactivated until after phase 2 has expired. The IK and IK1 currents are described later in this video. Now go with calcium ion conductance during the plateau. The calcium ion channel are voltage regulated channel that are activated as potential difference become progressively less negative during the upstroke of the action potential. Various types of calcium ion channel have been identified in cardiac tissue, but this discussion concentrates on the predominant channel, so-called L-type calcium ion channel. Some of important characteristics of this channel are illustrated here in this figure. This diagram is for fractional activation of the calcium ion current to -30 to +30. Note also that after the invert current reach its maximum value in downward direction, it returns to zero only very gradually. That is, the channel inactivate very slowly. Thus, because the current that passes through this channel is long lasting, the channel are designated L-type. Opening of the calcium ion channel is reflected by an increase in sodium ion conductance immediately after the upstroke of an action potential. At the beginning of the action potential, the intracellular calcium ion concentration is much less than the extracellular calcium ion concentration. Consequently, the increase in conductance of calcium ion promote an influx of calcium ion into the cell throughout the plateau. This influx of calcium ion during the plateau is involved in excitation-contraction coupling, which we will discuss in next video. Various factors such as neurotransmitter and drug may substantially influence calcium ion conductance. The adrenergic neurotransmitter, norepinephrine and epinephrine, the beta-adrenergic receptor agonist, isoproteanerol, and various other catecholamine may enhance of calcium ion conductance. Catecholamine is probably the principal mechanism by which the enhanced cardiac muscle contractility, whereas neurotransmitter acetylcholine will decrease the conductance. To enhance calcium ion conductance, catecholamine first interact with beta-adrenergic receptor in cardiac cell membrane. This interaction stimulates the membrane-bound enzyme adenyl cyclase, which raise the intracellular concentration of cyclic AMP. This rise in level of cyclic AMP enhance the activation of L-type calcium ion channel. And thus augment the influx of calcium ion into the cell from the interstitial fluid. Conversely, acetylcholine interact with the muscarine receptor in the cell membrane that inhibit adenyl cyclase. In this way, acetylcholine antagonizes the activation of calcium ion channel and thereby diminishes conductance of calcium ion. The calcium ion channel antagonist are substances that block calcium ion channel. Examples include the drug verapamil and diltiazem. These drugs decrease the conductance of calcium ion, thereby impeding the influx of calcium ion into myocardial cell. The calcium ion channel antagonist decrease the duration of action potential and diminish the strength of cardiac contraction, which is showing here. Paradoxically, although calcium ion channel antagonists have a depressant effect on the contractile strength of the heart, these agents are used widely in the treatment of congestive heart failure. Congestive heart failure, a common clinical condition in which the contractile performance of the heart is already compromised. As a result, the heart is unable to generate enough blood flow to meet the need of the tissue. The calcium ion channel antagonist weaken the cardiac contraction and depress the contraction of vascular smooth muscle, thereby inducing generalized vasodilation. This diminished vascular resistance reduces the counter force, which is afterload, that opposes the propulsion of blood from the ventricles into the atrial system. Hence, vasodilator drugs such as calcium channel antagonist are often referred to as afterload reducing drug. This ability to diminish the counter force leads to a more adequate cardiac output, despite the direct cardiac depressant effect of this drug. Now go with the potassium ion conductance during the plateau. During the plateau of the action potential, the concentration gradient for calcium ion across the cell membrane is virtually as same as it is during phase 4, but potential difference is positive. Therefore, both the chemical and electrostatic forces favor the efflux of calcium ion from the cell. If conductance of potassium ion were the same during the plateau as it is during phase 4, the efflux of potassium ion phase 2 would greatly exceed the influx of calcium ion, and a sustained plateau could not be achieved. However, potential difference approaches and then attain positive value near the peak of the action potential upstroke. Conductance of potassium ion suddenly decreased. The diminishes potassium ion current associated with the reduction in potassium ion conductance prevent an excessive loss of potassium ion from the cell during the plateau. This reduction in potassium ion conductance at both positive and low negative value of potential difference is called inward rectification. Inward rectification is characterized of several potassium ion current, including IK1, has been determined by voltage clamping cardiac cells. Note that for the cell depicted in the figure, the current voltage curve intersects the voltage axis at a potential difference of about -70 millivolt. The absence of ionic current flow at the point of intersection indicate that the electrostatic force are equal to the chemical forces at this potential. In this ventricular cell preparation, Nernst equilibrium potential for the potassium ion is -70 millivolt. This value reflects the ratio of intracellular to extracellular potassium ion concentration that prevail in this particular experiment. This experiment is inwardly rectified potassium ion current recorded from a rabbit ventricular myocyte when the potential was changed from a holding potential of -80 millivolt to various test potential. Positive value along the vertical axis represent outward current, negative value represent inward current. The potential difference coordinate the point open circle at which the curve intersects the x-axis is the reversal potential. It denotes the equilibrium potential at which point the chemical and electrostatic forces are equal. Now, when the membrane potential is clamped at a level of to -70 millivolt, in this same isolated cardiac cell, the electrostatic forces exceed the chemical forces and inward potassium ion current is induced by the negative value of potassium ion current over this range of voltage. Note also that for potential difference more negative than -70 millivolt, the curve has a steep slope, even a point of intersection at which potential difference and equilibrium potential are equal at the point of intersection. Thus, when potential difference equal to or is negative to equilibrium potential, a small change in potential difference induces substantial change in potassium ion currents. That is, conductance of potassium ion is large. During phase 4, the potassium difference of a myocardial cell is slightly less negative than the equilibrium potential. The substantial conductance of potassium ion that prevail during phase 4 of the cardiac action potential is accounted for mainly by IK1 channels. When the transmembrane potential is clamped at a level less negative than minus 70 millivolt, the chemical forces exceed the electrostatic forces. Therefore, the net potassium ion current is directed outward, as denoted by the corresponding positive value of potassium ion current. Note that for potassium difference value less negative than minus 70 millivolt, the curve is relatively flat, and for potential difference value less negative than about minus 30 millivolt, the potassium ion current is virtually zero. Thus, at potential difference value that prevail during the action potential plateau, the efflux of potassium ion through IK1 channel is negligible. Conversely, the inward directed potassium ion current is substantial for those value of potential difference that prevail during phase 4. Thus, the IK1 current is inwardly rectified. The characteristic of another potassium ion channel, the delayed rectifier IK channel, also contribute to the low potassium ion conductance that prevail during the plateau. These potassium ion channels are closed during phase 4, but they are activated by the potential that prevail toward the end of phase 0. However, activation proceeds very slowly during the plateau, hence activation of this channel tend to the increase potassium ion conductance very gradually during phase 2. Thus, this channel play only a minor role during phase 2, but they do contribute to the process of final repolarization. At phase 3, the action potential plateau persists as long as the efflux of charge carried mainly by potassium ion is balanced by the influx of charge carried mainly by the calcium ion. Let's go with the phase 3 genesis of final repolarization of fast response. The process of final repolarization phase 3 start at the end of phase 2, when the efflux of potassium ion from the cardiac cell begin to exceed the influx of calcium ion. As we have noted, at least 3 outward potassium ion current I2, IK and IK1 contribute to the final repolarization phase 3 of the cardiac cell. The transient outward I2 and delayed rectifier IK current help initiate repolarization. These currents are therefore important determinant of the duration of the plateau. For example, the plateau duration is substantially less in atrial than in ventricular myocyte. Electrophysiological experiment reveal that the intensity of outward potassium ion current during the plateau is greater in atrial than in ventricular myocyte. When outward potassium current exceed the inward calcium ion current, repolarization begin. Hence, the greater potassium ion current during phase 2, the earlier repolarization begins. The greater density of potassium ion current in atrial than in ventricular myocytes account for the shorter action potential in atrial than in ventricular myocyte. The action potential duration in ventricular myocytes vary considerably with the location of these myocytes in ventricular wall. The delayed rectifier IK current appear to account for these differences. In endocardial myocyte, where the action potential duration is least, the intensity of IK is greatest. The converse applied to the mid-myocardial myocyte. The intensity of IK and the action potential duration are intermediate for the epicardial myocyte. The inward rectified potassium ion IK1 does not participate in the initiation of repolarization because the conductance of this channel is very small at the range of potential difference value that prevail during the plateau. However, the IK1 channel do contribute substantially to the rate of repolarization once phase 3 has been initiated, as the net efflux of cation causes potential difference to become increasingly negative during phase 3. The conductance of the channel that carry the IK1 current progressively increased. Now let's talk about phase 4, restoration of ionic concentration in fast response. The excess sodium ion that entered the cell rapidly during phase 0 and more slowly throughout the cardiac cycle is eliminated by the action of enzyme sodium potassium ATPase. This enzyme ejects 3 sodium ion in exchange for the 2 potassium ion that has excited from the cell mainly during phase 2 and phase 3. Similarly, most of the excess calcium ion had entered the cell mainly during phase 2 is eliminated principally by the sodium calcium exchanger, which exchange 3 sodium ion for 1 calcium ion. However, some of calcium is eliminated by ATP driven calcium ion pump. During phase 4, the chemical 60 mV and the electrostatic 90 mV forces favor influx of sodium ion from the extracellular space. Influx is negligible, however, because the activation M gate are closed. Let's talk about slow response. Fast response action potential consists of 4 principal components: an upstroke and partial repolarization, a plateau, and a final repolarization. However, in the slow response, the upstroke is much less steep. Early repolarization phase 1 is absent. The plateau is less prolonged and not as flat, and the transition from the plateau to the final repolarization is less distinct. Blocking sodium ion with tetrodotoxin in a fast response fiber can generate slow response under appropriate condition. The Purkinje fiber action potential showing clearly exhibit the 2 response type. In a control tracing, a typical fast response action potential display a prominent notch which separate the upstroke from the plateau. In action potential B to E, progressively, large quantity of tetrodotoxin are added to the bathing solution to produce a graded blockade of fast sodium ion channel. The upstroke and notch become less prominent. In the action potential B to D progressively. In action potential E, the notch has disappeared and the upstroke is very gradual. The action potential resembles a typical slow response. Certain cells in the heart, notably those in SA and AV nodes, are normally slow response fiber. In such fiber, depolarization is achieved mainly by the influx of calcium ion through the calcium ion channel. Depolarization is accomplished in this fiber by the inactivation of the calcium ion channel and by the increased potassium conductance through the IK1 and IK channel. Thank you. Don't forget to like, share and subscribe my channel.